Hi there! We've just learned about diabetes and about the surgical aspects of transplantation, and we will now discuss two cases of patients with diabetic nephropathy. So please think with us and use the decision tree you've already seen before. So the first patient is a 36-year-old female with diabetes mellitus since early childhood. Insulin treatment was started after the diagnosis. She developed hypertension and she has stage 4 chronic kidney disease with a creatinine clearance of 25 mL per minute. She can still work full-time as a teacher. Her major complaints are unstable glycemia with high glucose concentrations and sometimes also hypoglycemic events. So we will now ask Professor de Koning and Dr. Huurman to comment on this case.
Hello everyone. Well, first I would like to make sure which type of diabetes is present. The onset of diabetes in early childhood and initiation of insulin treatment is suggestive for type 1 diabetes. Another indicator of type 1 diabetes would be the presence of autoantibodies against beta cell epitopes at any time since diagnosis of her diabetes. With regard to making a correct diagnosis of her kidney disease, I would be interested to know her average HbA1c as a marker of glycemic control over the last decade. In general, patients with type 1 diabetes who present at a younger age with severe kidney disease have had poor glycemic control for long time periods. Proteinuria is often present. If she has diabetic retinopathy, it is also more likely that a nephropathy is due to her diabetes. Additional blood, urine, and ultrasound investigations, sometimes including a kidney biopsy, have usually been performed before referral to exclude other causes of kidney disease. So this patient has stage 4 chronic kidney disease for which a kidney transplantation is indicated and severe beta cell failure due to type 1 diabetes that makes her a candidate for beta cell therapy. What transplantation strategy shall we adopt? Let's use the decision tree. This patient is not yet on dialysis. It would be informative if we know the decline in kidney function over the past years in order to estimate when dialysis is likely to be initiated. In addition, it would be informative to know the average time on the waiting list for a deceased donor kidney and simultaneous pancreas kidney transplantation. If it is anticipated that the patient can be transplanted before or shortly after the initiation of dialysis, a decision needs to be made whether an additional pancreas transplantation is an option. But is the patient fit enough to have a pancreas transplantation in addition to a kidney transplantation during the same operation? From a medical point of view, this young patient with no relevant additional comorbidity would be a good candidate for simultaneous pancreas kidney transplantation. But how about potential contraindications from a surgical perspective? Let's consult one of the transplantation surgeons in our hospital, Dr. Huurman.
Hi there. Well, from a surgical point of view, simultaneous pancreas kidney transplantation is feasible. The iliac vasculature is not compromised in this young patient. The patient does need to be informed about the additional risks of pancreas transplantation when compared to kidney transplantation alone.
This patient received a simultaneous pancreas kidney transplantation. She had an uneventful post-operative recovery. Both kidney and pancreas transplant function were excellent after the transplantation. No more insulin, no more hypos, no more uncertainty about unpredictable glucose fluctuations. This procedure has improved her quality of life considerably. So, what have we learned from this case? For young patients with diabetes mellitus due to severe beta cell failure, such as type 1 diabetes, and stage 4 or 5 chronic kidney disease, a preemptive simultaneous pancreas kidney transplantation is the preferred transplantation strategy.